So after you've done a gait exam and you're confident that this is musculoskeletal disease and not neuromuscular disease, I do a standing exam. And really what I'm looking for here is asymmetry. Primarily in the back end, I'm going to look for generalized muscle atrophy. I think the largest muscle mass tends to be in the hamstrings, so I'll just feel here and I'm looking, is there any difference between the left and the right legs? But I will palpate over the pelvis and then come down. I'm not only feeling for muscle atrophy, but is there any swellings, any thickenings? Are the straight patellar tendons the exact same size? Are the joints the same size? On the front legs, same thing. And generalized muscle atrophy, I think, is easiest to compare left and right over the spines of the scapula. But again, I have to palpate for selective muscle atrophy over the entire leg, all of the muscle masses. I'm also palpating, are there any joint thickenings or any swellings? And I'm just trying to determine, is there any asymmetry between the left and the right leg? So after a standing exam, then we'll do lateral recumbency. Come on, sweetheart. In the rear leg, a couple basic principles. One, we want to start distal and work proximal. The other thing you want to do is check for bone pain above and below the joint before we check for joint pain. So I'll look at the pads, check the nail beds, make sure everything's okay there. Then I'm going to palpate for thickenings, swellings in each of the joints without really inducing any discomfort at all. I'm palpating for bone pain. Is there any abnormal reaction? Any swellings, thickenings, any bone pain? But then I check for flexion and extension. Then I'll go up to the hock. Is there any bone pain? Distal tibia or in the metatarsals, the calcaneus. Is the calcaneal tendon normal? Is there any pain if I flex the hock? And again, if I extend the hock. I'm going to come up to the knee, palpate for bone pain in the proximal tibia, the fibula. Is there any pain in the distal femur? When it comes to the knee, and there's other videos that complement this, I want to check for cranial drawer. I'm going to find 4 bony landmarks: the patella, the lateral fibula, the tibial tuberosity, and the head of the fibula. My thumbs here on the lateral fibula and the head of the fibula, I push down a little bit and I just roll them back behind those muscle masses. I don't want to come back and push forward. I'm going to get more muscle in there and I may trap the peroneal nerve. So put them on the bony masses and roll caudal. And then I'm checking for cranial and caudal drawer. Is there any femoral tibial translation? Motion like this. I don't want any motion like that. The other thing I'm going to do is I'm going to feel the quadriceps muscles coming down to the patella and also identify the tibial tuberosity. I put my fingers on the patella and I push a little lateral. While the leg is in extension, I push a little lateral, push a little medial, see if I get that patella to luxate. Finally, is there a full range of motion or any pain in flexion or extension? You can always be more aggressive the second time around. So don't be super aggressive the first time you're checking a joint. When it comes to the hip joint, is there any pain, particularly if I press down on the hip joint? Slowly abduct and try to get that knee pointed to the ceiling. A dog with normal hips will allow you to do this. If they have hip pain, they will resist that. Flexion, and then nice and slow, get extension. If I try to overextend, you'll make even a normal joint have discomfort. So that's kind of the exam on the rear leg. The front leg, pretty similar. I'm going to look at the pads. Again, check the nail beds, make sure everything's okay. Feeling for bone pain, any swellings or thickenings in the digits, the metatarsals, flexion, extension. Is there any bone pain in the distal radius or distal ulna? Any pain or thickenings of the carpus, metacarpal bones? Flexion, full range of motion without pain, and extension. Again, full range of motion without pain. Comes to the elbow, one thing that's challenging for many people is to separate elbow pain from shoulder pain. First, I'm going to check for bone pain in the proximal radius, in the proximal ulna, the distal humerus. Right here, between the lateral epicondyle and the olecranon, there's a groove. I put my finger in that groove where the anconeus muscle is. It should be nice and deep. And in a normal elbow, I can get that in there and I can feel the joint, feel the bones. If there's this is a really early area where osteophytes form. Instead of there being groove, there'll be kind of a bump, or you won't be able to discern a groove at all. So instead of extension, if I want to separate elbow pain from shoulder pain, I stabilize that shoulder joint, and I bring the elbow in full flexion. So the elbow is flexing, but the shoulder is not moving at all. And you can see that there's no discomfort. I can then gently do extension as well. For the shoulder, again, I want to palpate for proximal pain of the humerus, any pain on the scapula. I'll palpate just medial. Here's the greater tubercle. Medial to that is the biceps tendon. I'll press on that biceps tendon in there, make sure there's no pain. At this stage of the game, I want to make sure this elbow is not painful. I'll stabilize the scapula, so I put my hands here on the dorsal spine of the scapula and stabilize that scapula. Stabilize the elbow joint, and then I can flex the shoulder hard without the elbow being moved at all. While the elbow's in a neutral position, I can check the shoulder joint. After that, I can check for shoulder extension and make sure that there's no pain. So again, the main things: start distal, work proximal, check for bone pain below and above a joint before you check for joint pain.